Good afternoon and welcome to Life, Death, and What Matters in Between. I'm your host, Perry Limes, and today I have with me my esteemed colleague, Dr. Eric Bush, Chief Medical Officer for Hospice of the Chesapeake. Thank you so much, Dr. Bush, for your time, and let's get started. First of all, Dr. Bush, I'd like you to tell us a little bit about yourself, background, and tell the audience all about you.
Sure. Thanks so much, Perry. Appreciate the opportunity to be here and educate. Always a good thing. So, my healthcare career started out back in 1988, so a little over 30 plus years ago, as a medic in the Army Reserve. During my time in the service, I was able to get my LPN, then decided to go on to pharmacy school. Had a little 20s life crisis, did my MBA, got lost in the pharmaceutical industry, went back to med school at 30, spent a lot of time working at local regional cancer institute in Buffalo, Roswell Park. Is really what got me back into it. And completed my med school, ended up here in the Maryland area for a fellowship at NIH. Maryland has been great to me. Met my wife in medical school, as I said, then she was the boss, still the boss now. And I am boarded in internal medicine, hospice and palliative medicine, and addiction medicine. I've been doing hospice and palliative for the last 15 years, seen tens of thousands of patients at this point in time. Been very blessed to have the opportunity to work for a series of not-for-profit organizations, many of the community-based, some hospice-based, some not. And I've been here with Hospice at Chesapeake Supportive Care, as the Chief Medical Officer for the last approximately 6 years. Great organization, great heart, great mission, and that's me in a nutshell.
That is awesome, and thank you for your service.
Thank you. You too.
Fellow Army vet.
Exactly. Fellow Army guy. Absolutely. You too, my
Appreciate
friend.
it. So, what we would like to delve into is the journey with dementia. As we know, we're seeing more and more of a rise in dementia cases, in particularly on the end of life spectrum. I think as medicine starts to dive into it, whereas hospice has primarily been focused around cancer and maybe cardiovascular disease, dementia is probably, I wouldn't say a new diagnosis, but something that hasn't been looked at as the forefront. So before we get started with the audience, could you tell us what is dementia?
Sure. So dementia is a general term for loss of memory, language, problem solving, and other thinking abilities that are severe enough to interfere with daily life. Often when people think of dementia, they think of Alzheimer's dementia, which is the most common cause of dementia.
Awesome. And many times we hear about dementia, we think of an older person kind of sputtering along and forgetting certain things. Who is most at risk of developing this particular dementia diagnosis?
Yeah, sure. It's a great question. That's a little more complicated. There are some genetic links with certain types of dementia. There are actually 5 different types of dementia. There's Alzheimer's disease, which again is the most commonly known and most common type. The consequence of an abnormal shrinkage of the brain. There's also dementia with Lewy bodies, vascular dementia. And so vascular dementia, for example, is one where if you have a lot of times different chronic progressive medical issues that affect the body's cardiovascular system. So say you have some heart disease, some hypertension, diabetes, kidney disease, peripheral arterial disease, peripheral vascular disease. So those comorbidities would exacerbate or accelerate the progression of dementia. There's also frontotemporal dementia as well as mixed dementias, and these are things that I've seen And so there are things that can accelerate, or instigate progression of these diseases. And so trying to live a healthy lifestyle, healthy diet, avoid smoking, tobacco, cigarettes, alcohol, things of that nature. Those are things that, in addition to diet and exercise, can help prevent, to some degree, these dementias.
No, I truly appreciate that overview, because I think many times individuals think of dementia as just more of a mental disease, that it's not affecting the total body. And it seems like the total body is still obviously it's linked to the brain, but there's some other issues with physical debilitation. Would you agree with that?
Oh, absolutely. And so, one of the statistics to keep in mind is that mo- the average patient, after being diagnosed with dementia, has life expectancy of 4 to 8 years. Now, it can be longer. Some patient dementia may live up to 20, but again, you have to remember that average of 4 to 8. It is one of those disease processes where I've seen great caregiving can help um, amplify or help maintain quality as well as quantity of life. Um, but I want to pick up on something you said earlier with regards to, then cancer. Dementia and non-cancer diseases are definitely different than cancer. And so I think of something like cancer as a catastrophic disease, right? It's a catastrophic illness, often, unfortunately, because there's some out there like pancreatic where there are not good screening tools, and so patients tend to get diagnosed late. Alternatively, sometimes with dementia, you see patients get diagnosed late because there's people out there who have been very educated previously and are able to kind of hide some of their symptoms, or they have a spouse who still has, full capacity, and is able to kind of hide or cover for them their symptoms as they have memory loss, as they tend to have physical decline. But that being said, whether you have a catastrophic illness, cancer, or a chronic progressive illness like dementia, heart failure, COPD, kidney disease, they're both fatal, just at different time frames. And so, again, how do we as a society, especially given the silver wave that's occurring, and large swath of patients that are coming on, and the staffing challenges that we have, how do we make sure to educate people and maintain that high quality of care so that regardless of whatever illness you have, you're able to have both the best quality as well as quantity if possible?
Oh, that's awesome. So you talked about the progression of certain diseases. How do you see dementia, or I guess in your experience, the once somebody's been diagnosed, how fast do you start to see decline? Is it a slow descent, or is it something where it varies patient to patient in terms of decline?
Yeah, so it can vary from patient to patient. Before we get more into the medical stratification, I just wanted to delve in a little bit first into what makes the journey with dementia so challenging. And one of those pieces is that it can have a lot of individual twists and turns. And within the different types of dementia themselves, they can have different rates of progression. I've had some patients
Mm.
with Alzheimer's go on for years, whereas dementia with Lewy bodies, vascular, or frontotemporal tend to be more accelerated in nature. Frontotemporal sometimes, as well as Lewy body, can have more behavioral disturbances, which are very challenging. But regardless, the practical challenges tend to be fairly universal, and uh, with challenges overall, including practical, which includes safety and security. There's dealing with finances and legal issues. A lot of times you see couples where I know even my wife and I, we delegate certain tasks to one another. So dealing with things like finances, and as somebody with dementia loses that, quote unquote, executive function ability to balance the checkbook, sometimes they run into financial issues, which their spouse isn't aware of. And then there's also, in this day and age of making sure that we all have protection, can get into legal issues with regards to who can be the medical power of attorney, financial power of attorney, if that hasn't been delineated as of yet. Patients with dementia sometimes, especially what we just went through and are still coming out of with the COVID pandemic, can be isolated and get bored, which then can lead to changes in behavior, such as agitation. Then there's some of the physical challenges of dementia, which include dealing with incontinence, both urinary and fecal, which each have their own challenges, manage bathing and dressing, as well as other activities of daily living, such as eating, which tends to then restrict mobility both for the patient and caregiver, and impacts on sleep and rest. And then there's the emotional challenges, first for the patient. Again, some patients sometimes do have aggression. Some patients get paranoid or suspicious and can have hallucinations. Patients with Lewy body dementia tend to have more hallucinations at times. And part of the challenge is the medications that we use intervene when somebody has aggression, paranoia, or suspicion. They have their own set of risks, and we know that the majority of those medications actually have a negative mortality benefit, that they can cause someone to die sooner. So then you look at non-pharmacologic interventions, which can be very challenging as somebody has behavior that's escalating, or if you have, a caregiver who is much more diminutive in nature than the patient themselves. And so this often leads to challenges for the caregiver, those providing care. They need to take care of themselves, but often they don't have somebody to give them a rest. And then, eventually, once the disease takes its course and the neurologic progression leads to physical progression, where the patient is no longer able to bathe themselves, comb their own hair, put on their own clothes, toilet themselves, feed themselves, and their vocabulary has diminished to a degree, and the patient isn't even able to sit up or smile. But deciding when to let go and when to bring in, hospice care, hopefully for that supportive or palliative care. So that there's a lot that's wrapped up in this, and the numbers are, very, very large with regards to concern about, the next 20 to 30 years in this country, and that inversion of the pyramid, and how do you have enough caregivers, both in the healthcare community as well as lay people, to care for patients that are likely to suffer from any type of dementia.
Wow, wow, great information. You brought up hospice and palliative care because, we are talking about kind of more the end of life spectrum. What is the role of palliative care or supportive care, as we like to call it, when it in regards to dementia, and how does that affect the patients?
Sure. Great question, Perry. Supportive care is really appropriate anytime after a dementia diagnosis and some tangible decline. There's some varying recommendations. There's something called the Global Deterioration Scale. And if you look at that, some people recommend Stage 2, which is a little bit early, but probably if you don't have delineated advance directives, if you don't have a power of attorney, if there's complicated family dynamics, that would be a good time. But I think for most of the people, when you get to global deterioration scale of what we call stage 4, where the patient has reduced ability to count, finds travel difficult. This includes doctor's offices, right? Used to be able to take grandpa to go see Dr. Smith, who is about 10 minutes away, and now instead of taking 20 minutes to get him
Right.
ready, it takes 2 hours just to figure out how to get him dressed, get him in the car. And you have a patient who can no longer manage their own affairs. I think that's a good time to at least have an initial palliative or supporter consultation, because there's so much that can be done. Palliative or supportive care can see you at your home. If there are those mobility difficulties, there is often either a physician or nurse practitioner, a medical provider that will come see you at home to address any physical symptoms, to address progression of disease. But in addition to that, there is social work help, as well as nursing help that can come and see triage. Again, it's not 24/7 care, but it is an additional layer of support, and a layer of support that can help guide decision making with regards to risk benefit, and again, trying to figure out how you optimize that quality as well as quantity of life, because while med has gotten better technologically, everything we do still comes down to risk versus benefit. And even the medicines that are commonly used for dementia, Namenda and Aricept, are really best when somebody first has mild or maybe moderate dementia to some degree. Once you get to somebody with that severe degree of dementia, those medicines actually have more risk than benefit. So the earlier you can get these things implemented, the earlier you can get help for patients and families, so there's not that isolation, so the caregivers don't feel isolated and end up getting burned out. I think that's the time when you get supportive or palliative care involved.
Awesome. Um, with that said, and you brought up the fact about getting palliative care and possibly hospice, but the dementia patient sees their primary care physician. I'm sure they at times end up at the hospital. They may even go, because of their age, to a nursing home. And you hear this term or this phrase, continuum of care. Can you help the audience understand what that means and how it also relates to the hospice patient, or excuse me, to the dementia care patient?
Sure. Great. Thanks, Perry. So, in medicine, continuum of care refers to the delivery of health care over a period of time. And the other piece that's great about supportive care or palliative care, a lot of times these are delivered by organizations like ourselves that are also hospice organizations that are not for profits. And so what we want is that continuum to be continuity. And so we want that provider that goes to see that patient, that goes to see that family, be the one that continues to provide care. The patient gets diagnosed with, say, Alzheimer's dementia. They get supportive care, palliative care in there early, say just after. And again, as we talked earlier, on average, these patients live 4 to 8 years. Let's say this patient is going to live 8 years. Let's say 2 years in, the patient starts seeing palliative care. And for those first 5 to 5.5 years, the patient family are able to benefit from those interventions that supportive care can provide. like the guidance regarding symptom management, the guidance regarding social work, identifying resources, because as you noted, these patients often do get hospitalized. As dementia progresses, patients often do get dysphagia with a G, which is difficulty swallowing. And when they develop this difficulty swallowing, they end up with something we call aspiration pneumonia, where they get food that goes into the lung, develop subsequent infections. And again, we know that the risks of having PEG tube or feeding tube in place for these patients, again, the risk of doing that outweighs the benefit with regards to PEG tubes. So that's really not an option. So how do you modify somebody's diet so that it's safe? Make sure that you treat somebody's aspiration events appropriately, but also know when it's time, if somebody's had recurrent, say, aspiration events and they have moderate or severe dementia, that's the time where you really need to look and say, hey, this is a time for hospice, where we can have, dad, grandpa, grandma at home, and hospice can come in and provide that care at home. There's 24/7 access to care if need be. Somebody can come out in the middle of the night, triage something, troubleshoot something. Again, we know that more often than not, as time goes on, patients will develop things like agitation that are very difficult to control, and you really need the healthcare expertise. So that's what I feel would be, most optimal, most beneficial, and hopefully that's how the continuum of care could be the continuity of care, where you have a provider that starts out seeing the patient for supportive or palliative purposes and sees them all the way through, and is then there and able to provide bereavement services thereafter for the surviving family members.
Oh, that's awesome. I think it's challenging sometimes, where so many different individuals and caregivers touch this patient, and making sure that the communication is pretty fluid between all of those. But a lot of times it gets to that end point, and I know the hospice word is the scary H word that floats around as a specter or ghoul in the night, but it's actually a beautiful service. And I think you touched on some of those points. Is there anything else you would like to elaborate on regards to hospice care when it comes to the dementia patient?
Yeah, so I just think it's such all-encompassing care. With hospice care, you get the medical care to alleviate symptoms and pain, and not just pain, but agitation. And again, hopefully you have the same provider, so some of those patients that may get paranoid, or family members that, have done such a phenomenal job and invested so much time and have that relationship with a provider, they're able to continue that all the way through. But hospice also provides counseling about emotional and spiritual impact of the end of life, not just with social workers, but one of the things I strongly believe in is really the power of chaplains. And I think when people think of chaplains, they think of faith-based and very religious, and it can be that for people if they want it to be, but it's really there for spiritual support and counseling support, because this is really about grieving for your loved one and grieving for yourself and time that you lost and all that you've put in, and so it can be another support. The other great thing about hospice, the hospice benefit, there are multiple different levels of hospice care that can be provided, and that's a whole other talk unto itself, as you know. And but one of the great benefits with hospice is something called respite care, and respite care is a 5-day benefit where the patient can go to a facility, either a skilled nursing facility or an organization like ours, where we have inpatient care centers, We take with patients all the time. We have several right now that I'm caring for at our inpatient care center, and it allows the family to get a much needed break. They get those 5 days, or if, maybe things have gotten to the point where the family needs to transition their loved one to a skilled facility, they can come into our inpatient care center initially for respite and then transition to routine level of care as placement is sought. It's just such a huge benefit, and really gives caregivers, especially that may have some degree of burnout, a break, much needed break. And then the other point with regards to services that I can't overemphasize the benefit is really the grief support for the family, bereavement services, and our Chesapeake Life Center, and just the tremendous job they do, whether it's individual or group, and those services are provided, free. They're part of our mandate from CMS, and we provide those for up to 13 months for loved ones of the deceased thereafter. And again, it's just a way to help work through those feelings, work through those emotions, and try to process that loss, and try to heal as much as that is possible.
Oh, so beautiful, so beautiful.
Thanks.
So, Dr. Bush, some of with all this great information that you've shared with us, from your medical perspective, what would you want a person with dementia or their family to know that they may not be aware of right now?
Sure. You're not out there alone. There's a lot of resources that are out there. There is Alzheimer's Association, which speaks to supportive palliative care, neurologic care, hospice care, the whole spectrum of care, which is www.alz.org. There is also getpalliativecare.org. We also have our Chesapeake supportivecare.org for those that are in our service area, which is mid-Maryland, so Anne Arundel County, Prince George's County, Charles County, all those areas. And so there's a lot of resources out there. You don't have to go it alone. Do definitely speak with your provider, whether it's in the case of dementia, whether it's your neurologist, your primary care physician, and ask them about supportive or palliative care is a great way to start off the conversation, and ask early. So if you've received that diagnosis, knowing that unfortunately on average the life expectancy is 4 to 8 years after diagnosis, there's nothing wrong with getting supportive or palliative care involved early, whether it's for symptoms or guidance or social support. And it's something we can titrate the visit frequency as time goes on, and as the symptoms or disease progression worsens, unfortunately, as time goes on, we can increase the intensity of care later on. But it's just great to have our foot in the door, so to speak, and get a sense of that patient and how they are, and form that bond with the patient family so that we know we're doing everything we can in order to make sure, again, to optimize both that quality and quantity of life for the patient.
Wow. With that said, what a perfect way to summarize this discussion. Dr. Bush, thank you for the invaluable information that you shared with us.
Sure.
I am sure that you have touched many families and patients with this much needed information. We would like to thank the John and Kathy Belcher Institute for your generous support on Hospice of Chesapeake's endeavors in education and community outreach as well. Thank you so much for your time today.